You are audible. So we will go live in 3, 2, 1. Over to you, sir.
Thank you. Good evening to all. I am Paresh Prabhugaonkar. On behalf of Nirvin Life Sciences, I welcome you all for this live webinar on advances from ASH 2021 on DLBCL and follicular lymphoma. I welcome all the distinguished faculties and delegates who have joined this webinar today. Also, I extend my warm welcome to Dr. Brad Kahl. He has been kind enough to spare his valuable time with us today. Also, I welcome Dr. Professor M.B. Agarwal. He is an institution in himself. He doesn't require any introduction. I now request Professor Dr. M.B. Agarwal to take up the session ahead. Thank you, sir.
Thank you, Paresh. I'll just share my screen. So, good evening, friends. Today, our guest speaker is Dr. Brad Kahl from St. Louis. He's going to lecture on diffuse large B-cell lymphoma and follicular lymphoma, advances from ASH 2021. This webinar is brought to you by Mumbai Hematology Group. It is supported by Nirvin Life Sciences and managed by Mice Ideas. I thank Mr. Paresh Prabhugaonkar and his team, Nirvin Life Sciences, Rajesh Kalpesh and their team, Mice Ideas, Executive Committee of Mumbai Hematology Group, our guest speaker today, Dr. Brad Carl from St. Louis, all our discussants who are themselves very eminent hemato-oncologists, and you participants from almost 14 countries for sparing your Saturday evening. Tomorrow morning at 11:30 a.m. IST, we have Dr. Claire Harrison from London. She'll be speaking to us on myeloproliferative neoplasms. How do I treat in 2022? Our discussants today are various friends from various parts of India. We have Dr. Bhavin Shah from HOC Vedanta, Ahmedabad. Dr. Abhay Bhave from Lilavati Hospital, Mumbai. Dr. Javed Rasool from Sher-e Kashmir Institute of Medical Sciences, Srinagar, Jammu and Kashmir. Dr. Alim Jan from the former professor clinical hematologist KIMS, hematologist and hemato-oncologist, Srinagar, Jammu and Kashmir. Dr. Afaq Ahmad Khan from Department of Clinical Hematology, KIMS, Srinagar, Jammu and Kashmir. Dr. Prathamesh Kulkarni from Nanavati Super Speciality Hospital, Mumbai. Dr. Deepanjan Haldar from Jupiter Hospital, Thane, Mumbai. Dr. Deepesh Lat from Postgraduate Institute of Medical Sciences and Research, Chandigarh. Dr. Kripa Bajaj from Indo-American Cancer Hospital and Research Institute, Hyderabad. So a pleasure to introduce Dr. Brad Carl to you. He doesn't require any introduction. He's a huge personality in the field of lymphoma, and he has been our guest speaker in past as well. He is Professor of Medicine, Director of the Lymphoma Program, Washington University School of Medicine, St. Louis. He earned his medical degree from Tufts University School of Medicine, Boston. He then completed a residency in internal medicine and a fellowship in hematology at the University of Wisconsin. His research focuses on improving outcomes for patients with lymphoma through testing novel agents in well-designed clinical trials. He is chair of the ECOG Akron Lymphoma Committee since 2009, where he has facilitated the development of multiple large clinical trials. He helped successfully renew an ECOG Scientific Operations grant and led a successful effort to obtain a National Clinical Trials Network Lead Academic Performance Site Award for University of Wisconsin. He is the Washington University Principal Investigator for the LEO Consortium, a large molecular epidemiology effort funded by NCI. He is a member of the several professional societies, including ASH, ASCO, ECOG, Akron, US FDA Oncology Drug Advisory Committee, and NCI Lymphoma Steering Committee. He is a member of the Lymphoma Research Foundation Scientific Advisory Board and served as chair of the LRF Mantle Cell Lymphoma Consortium from 2012 to 2018. I invite him to lecture on DLBCL Follicular Lymphoma, Advances from ASH 2021. Over to you, sir.
Oh, thank you, Dr. Agarwal. Let me share my screen so I can get my slides. Can you see them okay?
Yes,
Okay, great. So it's my pleasure today to talk about a few abstracts that I thought were particularly noteworthy from the 2021 American Society of Hematology meeting. Here are my disclosures. So I selected three abstracts in diffuse large B-cell lymphoma. I thought it would be worth spending a few moments talking about the POLARIX study, which could indicate a new frontline standard of care using a antibody drug conjugate. I thought there were two very noteworthy abstracts looking at CAR T-cell therapy for high-risk relapsed refractory diffuse large B-cell lymphoma. And so I was planning on discussing ZUMA-7 and the TRANSFORM study. And then follicular lymphoma, there were a few noteworthy immunotherapy abstracts. I think we're getting a better sense for how good bispecific monoclonal antibodies might be in follicular lymphoma. And I'll talk about that in abstract 127. And then we've seen some data for CAR T-cell therapy in follicular lymphoma, and we have longer term follow-up. So I'll briefly mention abstract 93 and 131. And then at the end, I just threw in one last little abstract, because this was really the first time we had seen anything evaluating bispecific monoclonal antibodies in mantle cell lymphoma. And so I think we got a signal that there could be some efficacy. So these were the abstracts I was going to cover today. So first we'll talk about the POLARIX study. And R-CHOP has long been established as the standard of care in frontline for about 20 years now. Polatuzumab vedotin is an antibody drug conjugate, which targets CD79B and uses an MMAE cytotoxic payload. Obviously, the rationale for ADCs is to deliver cytotoxic therapy more selectively to tumor cells, which in theory should improve the therapeutic index of a cytotoxic agent and would allow one to deliver more potent cytotoxic agents than you could just administer intravenously. So this was the design of POLARIX. It was a global randomized phase 3 study for patients with previously untreated diffuse large B-cell lymphoma, adults, and they needed to have slightly higher risk disease, so they needed to have an IPI score of 2 to 5 to be eligible. The trial enrolled almost 900 patients globally, and patients are randomized to standard R-CHOP chemotherapy given with a placebo, or what we call R-CHP-POLA. So in R-CHP-POLA, the vincristine is subtracted, polatuzumab vedotin is added, and then these patients also received a vincristine placebo, and everybody was blinded to what the patients were receiving. So for example, we had this trial open at our center, and I enrolled several patients, and I never knew who was getting R-CHOP or who was getting R-CHP-POLA. So these are the baseline characteristics, and I won't spend too much time on this, but suffice to say the randomization worked. Median age is right where you would expect, around 65, 66. And the two groups of patients were well balanced for key features, including bulk, elevated LDH, time from diagnosis to treatment, Ann Arbor stage, extranodal sites, IPI score, cell of origin classification, and double expressor, double hit features. So, just looking at response rates for the two regimens, they came in fairly similarly, numerically slightly higher complete response rate for, can you see my pointer, by the way?
Yes, sir.
Okay, slightly higher response rate for R-CHP-POLA, 87% versus 83%. But here's really the top line results. The primary endpoint of the study is progression-free survival. And you can see there's a slight but statistically significant advantage for R-CHP-POLA compared to R-CHOP. There's not big curve separation here, but there is some curve separation. And the median follow-up at the time of the presentation is 28 months. And if you just look at the 2-year progression-free survival, it's 76.7% for R-CHP-POLA versus 70.2% for R-CHOP. Shown on the right here is the overall survival. And at the time of this presentation, there is no difference in the overall survival between the two regimens. So what about toxicity? Well, the toxicity profiles of the two regimens look remarkably similar. Polatuzumab vedotin can cause peripheral neuropathy, much like vincristine, and so it turns out there wasn't much difference in the risk of peripheral neuropathy between the two regimens, whether it be any grade or grade 3-4. Not much difference in nausea or neutropenia or diarrhea, or really any other side effect that one commonly experiences with R-CHOP chemotherapy. Maybe a teeny bit more febrile neutropenia with R-CHP pola compared to R-CHOP. And if you just look at any grade serious adverse events, grade 3 or higher, 60% versus 60%. So, and really no difference in discontinuation of a study drug, or not much difference in dose reductions, a little bit higher in R-CHOP. So overall, my impression was the safety profile of the two regimens looked quite similar. So the conclusions from POLARIX for patients with intermediate or high risk, previously untreated diffuse large B-cell lymphoma, R-CHP pola significantly increased progression-free survival compared to R-CHOP. The hazard ratio came in at 0.73, which met the pre-specified outcome for success in this trial. I would say the adverse events characteristics were quite similar between the two treatment arms. And the investigators concluded that they thought these data supported the use of polatuzumab vedotin plus R-CHP in patients with untreated diffuse large B-cell lymphoma, and may represent a new standard of care in the front line. And we can talk about this in the question and answer, but that's my impression too. The toxicity is about the same and the efficacy is a little better. So, why wouldn't you use this, assuming it gets approval by regulatory agencies in the United States? R-CHP pola is not yet approved for frontline, but I am anticipating it will be. And then, it'll be interesting to see how the label reads and what the uptake will be like. I envision that I will be offering it to my patients, if they meet IPI score of 2 to 5, and have the same kind of characteristics as the patients that went into this study. Okay, so let's go to the next abstract. So this is ZUMA 7. And so now we're shifting to relapsed refractory diffuse large B-cell lymphoma. And the current second line treatment for patients who are candidates would be high dose therapy with autologous stem cell transplant consolidation, as this is a potentially curative strategy for patients who are appropriate. But the fact remains that many patients cannot receive high dose chemotherapy, autologous stem cell transplant. Maybe they don't respond to the salvage regimen. Maybe they're not a candidate because of age or comorbidities. And so there's a big unmet need in this group of patients. Axi-cel obviously is a CD19 directed CAR T-cell product, and it's currently in the United States, it's FDA approved for use in relapsed diffuse large B-cell lymphoma after failure of 2 lines of therapy. And that's how we've been using it, as standard of care. But this trial is looking to move it up into second line and compare it against standard of care in second line. So this was the design for ZUMA 7, another global multi-center randomized phase 3 trial. This was for patients who had relapsed diffuse large B-cell lymphoma, and they had to have, quote, high risk relapse disease, which means they have disease relapse or progression within 12 months of their frontline immunochemotherapy. So they could be primary refractory progressing through, or failed to get into CR, or they go into CR and they relapse within that first 12 months. And we know that those types of patients have worse outcomes with autologous stem cell transplant. Obviously, they're demonstrating some sort of inherent chemotherapy resistance if you're relapsing that quickly. So patients enrolling to this trial, and there are over 350 patients, would be randomized to the axi-cell regimen or standard of care. Standard of care in this case was 2 to 3 cycles of investigator-selected platinum-based immunochemotherapy, for example, RICE or DHAP or RGDP, depending on what the center selects. And then patients who respond to the salvage would receive high-dose chemotherapy autologous stem cell transplant. And the primary endpoint of this trial is event-free survival. And at the time of this presentation, the median follow-up is 25 months. So here's kind of the bookkeeping. 180 patients enrolled to axi-cell, 179 to standard of care. If we just focus on the top, most of the patients received leukapheresis, received their lymphodepleting chemotherapy, and received their axi-cell infusion. So 170 of 180, that's pretty good. Standard of care, you start to see the problems with the strategy for standard of care. So 168 go on to receive their salvage chemotherapy, but only 80 responded. And this is, what happens in real life. There's just a lot of patients who don't respond very well to their salvage chemotherapy, making them ineligible for stem cell transplantation. 69 go to leukapheresis and 64 get their high-dose chemo stem cell transplant. So here is the top-line results from this trial of event-free survival. The blue curve is axi-cell, and the red curve is standard of care. And so obviously there's a steep drop-off for patients who aren't responding to their chemotherapy salvage. And if you look at the 2-year mark, 40% of the axi-cell patients are event-free, and only 16% of the stem cell transplant patients are event-free. So this trial met its primary endpoint, demonstrating a big improvement in event-free survival for axi-cell. Obviously, more patients assigned to axi-cell went on to receive the therapy that they're assigned compared to standard of care. Now, the patients who were assigned to standard of care who didn't respond to their RICE or whatever, or who relapsed after stem cell transplant, they could cross over to axi-cell. So there is no overall survival difference at the time of this presentation. But the investigator conclusion, and I agree, is this could mark a paradigm shift where CAR T-cell becomes the preferred option for patients, these high-risk relapsed diffuse large B-cell lymphoma patients. And then a very similar study called Transform was also presented at ASH. So the design is quite similar. This was a multi-center phase 3 study. It's a smaller study, 184 patients. And patients were randomized to the Lysacel product. So this is a different CAR T product, or standard of care, which is 3 cycles of salvage followed by stem cell transplantation. So really the design is quite similar to what we just looked at in the Zuma 7. So this is the event-free survival per the independent review committee. Now the follow-up here is shorter, but again, we're getting that same kind of pretty dramatic curve separation. So here's standard of care, again, huge drop-off because patients aren't responding to salvage chemotherapy. And with Lysacel, much better outcomes. And, we don't have 2 years of follow-up here, but these curves are, looking like they're going to come in pretty similarly to what we saw in Zuma 7. We can estimate 12-month event-free survival rates here for Lysacel. Right now, it's 44% versus 23% for standard of care. And this is the same high-risk patient population as before, patients with relapsed large cell and had to progress within 12 months of their frontline immunochemotherapy. So this just applies to these high-risk patient population. So again, a big improvement in event-free survival with a big difference in the hazard ratio, better response rates for the CAR T product. I didn't really get into the toxicity, but there was really nothing unexpected. it just shows the kind of adverse event signals we've seen in every other CAR T study. There's a risk for cytokine release syndrome. There's a risk for neurologic toxicity, and there were no surprises there. But again, the results from Transform look very similar to ZUMA-7 and suggest that there should be a new second-line standard of care for these high-risk diffuse large B-cell lymphoma patients. Okay, so I'll shift gears now and just mention a couple of abstracts in follicular lymphoma. So I picked 3 immunotherapy abstracts, and the first one is looking at mosunetuzumab, which is a bispecific monoclonal antibody. As you know, bispecific monoclonal antibodies are engineered to bind to CD20 on lymphoma cells, but then also bind to CD3. So the idea here is to bring cytotoxic T cells in proximity to malignant B cells so that the T cells can kill the B cells. And so this is hopefully an quote off-the-shelf immunotherapy that one could administer to patients immediately without the need for T cell pheresis and T cell engineering and product manipulation and all those things. So a much simpler way to administer immunotherapy to patients. And this is a fairly large study that included a lot of dose finding for mosunetuzumab, but then they went into dose expansions in follicular lymphoma. And so now the study has a pretty large experience in follicular lymphoma, 90 patients now. And the way the mosunetuzumab is administered is a stepped up dosing strategy where patients receive just a very small dose on day 1, week 1, sorry about that, of 1 milligram, and then a 2 milligram dose a week later. And then they would get a very large dose on day 15, 60 milligrams. And then every 3 weeks is another cycle. Then they got another 60 milligram dose. And then it drops to 30 milligrams for cycles 3 through 8. If patients are in a complete response, they would stop after 8 cycles. If they're in a partial response, they could continue on the therapy for 17 cycles, which is approximately 1 year. So that was the treatment strategy. Patients needed to have relapsed follicular lymphoma and failed at least 2 prior lines of systemic therapy, including a prior anti-CD20 and an alkylating agent. So here's our patient characteristics. I don't think there's any big surprises here. The median number of lines of therapy is 3, and as expected, everybody's had prior anti-CD20, everybody's had prior alkylator, and then a handful of patients that had prior IMiD or PI3 kinase, et cetera. A little bit of a high-risk group. 68% were considered refractory to the last prior therapy. So, or had POD24, 50% of their initial therapy. So I would call this a moderately high-risk group of relapsed refractory follicular lymphoma based upon that, if they're not responding at all to their previous line or they had POD24 to their frontline therapy. So kind of a busy slide because they reported response rates by investigator and by independent review committee. So we'll just look at the independent review committee here. So they're calling the overall response rate for mosunetuzumab 80% with a complete response rate of 60% and good concordance between the 2 review groups. And if the patients were so-called double refractory to rituximab and alkylator, still had a good response rate of 70% with a complete response rate of 50%. And if they had POD24 to the frontline treatment, still a good response rate of 85% and a good CR rate of 57%. So pretty impressive, I thought, for response rates for this single agent off-the-shelf immunotherapy. Here are the waterfall plots, which, pretty impressive. Most patients are getting significant anti-tumor effect from this therapy. Here's the progression-free survival. And obviously the follow-up is not super long yet. You can see the furthest patients are just out at 2 years, and most of the patients are still in like 12 to 18 months. Right now, the median is at 18 months. This is probably a labile number because the curve is plateauing right around that 50% mark. So I have a feeling this number is going to change as the study matures. I don't know if it's going to get worse. It might actually get better. So I'm not putting too much stock in the median right now. And I'll be really interested to see how this data looks, a year from now. But I would say the durability is looking pretty good. Obviously, there are relapses occurring, but the durability is looking pretty good at this time. So what about toxicity? Well, there's definitely a risk for cytokine release syndrome with the bispecifics. You can see almost half the patients have some cytokine release syndrome. Fortunately, most of it is grade 1 and grade 2. Grade 3 and grade 4 is quite uncommon. And if you look over at the bar graphs on the right, you can see when the cytokine release syndrome occurs. So there's a little bit with that very first dose, and then the next week, not too much. And then when they come in for that big dose on week 3, then you get more CRS again. But then the CRS risk goes down quite a bit once you get into cycle 2 and beyond. So it pretty much is all in cycle 1. At the beginning of the study, patients were being hospitalized just for observation. But once they became more comfortable with the drug and the regimen, then patients were managed as outpatients. And then, a few patients would have to get readmitted because they were having high fevers due to cytokine release syndrome. But by and large, it became outpatient therapy later in the study. So mosunetuzumab in relapsed follicular lymphoma, I think, is looking impressive. Overall response rate of 80%, complete response rate of 60%. And this was a pretty high risk follicular lymphoma patient population. The toxicity profile looks, I think, okay. I didn't show all the toxicity data, but there really was a significant risk for infection or myelosuppression. Really, the main risk with the agent is the cytokine release syndrome, which appears to be confined to cycle 1. And once patients just get on their every 3-week dosing strategy, the treatment is quite easy to give. And we've had this trial open at our center for quite a while, and I've treated a number of patients with this agent, and it's been frankly easy to give this treatment to patients. So this is a very exciting treatment, not yet approved in follicular lymphoma, but I hope it will be someday. So I'm going to show 2 quick longer-term follow-ups for CAR T in relapsed follicular lymphoma. So here's longer-term follow-up of ZUMA-5. This is a single-arm phase 2 study of axi-cel in patients with relapsed indolent lymphoma. So there's a combination of follicular and marginal zone. So we've already talked about axi-cel in the ZUMA-7 data that I showed you a few minutes ago. And this data has been reported previously. This is just longer-term follow-up. But in the primary analysis with 104 patients, very high response rates, 92%, complete response rate, 76%. But the follow-up was pretty short. And so now we have a little bit longer follow-up of over 2 years. So here was the strategy. Patients for this trial had relapsed follicular or marginal zone lymphoma and must have failed at least 2 prior lines of therapy. And then they received axi-cel, the axi-cel product, and the usual strategy. So here's the older data on response rate. Again, 94% overall response in follicular, 79% complete. Here's the marginal zone, only 24 patients. Response rates are just a little bit lower in relapsed marginal zone. But here's longer follow-up on the progression-free survival. So the blue curve at the top is follicular lymphoma, and the green curve in the bottom is marginal zone, and then all patients combined is in yellow. And so the This is kind of hard to read on the slide, but the median progression-free survival is 39 months for follicular lymphoma. And if you just look at the 24-month rate of being progression-free, 63% for follicular lymphoma, 47% for marginal zone. So again, the data is looking pretty good with longer follow-up. I think we're going to need even longer follow-up to know how good this is. I'll be really curious to see how CAR T is performing at years 3 to 5, because obviously this is a treatment that incurs quite a bit of risk to patients for cytokine release syndrome and neurotoxicity and prolonged cytopenias. And so I think we really need to know the long-term potential of this treatment before we know how good it is. But I would say so far so good. So it's nice to see 2-year follow-up. They did give us a little bit of a more granular breakdown looking at people who had POD24. The results aren't quite as good in POD24 follicular compared to people without POD24, but they're still good with 24-month progression-free survival rate of 57% of POD24 versus 73% people without POD24. No new safety signals for axi-cel. There is some risk for grade 3 cytokine release syndrome and grade 3 neurologic toxicity. Fortunately, these things tend to be transient, short-lived toxicities, but of course they're very serious when they do occur. I think the big thing to look for in these CAR T-cell studies in follicular lymphoma are the long-term cytopenias. And we're really going to need to see this data broken down in a very granular fashion. They're saying grade 3 cytopenias present greater than 30 days post-infusion in 34% of patients. We need to know what the counts look like 100 days out, 6 months out, 12 months out. Because if your patient with follicular lymphoma relapses after CAR T and they have very poor bone marrow recovery, that really ties your hands for the administration of future therapies. So to me, that's the big unknown that we need to get a better handle on. Okay, and then there was one other CAR T relapse follicular study with longer term follow-up. This is the so-called ALERA study. This is looking at the T-cell product, so a different CAR T product. This had been previously reported in relapsed follicular, again, high response rates, 86%, complete response rate, 66%, but with very short follow-up. So the current analysis has slightly longer follow-up. It's still only 17 months, so I won't spend too much time on it, but here was the strategy. It was almost 100 patients with relapsed follicular lymphoma who received the T-cell CAR T product. There was optional bridging strategy, and the primary endpoint was the response rate. So again, response rates are nice and high, 86%, complete response rate almost 70%. The 12-month progression-free survival is coming in at 67%. So that looks pretty good, but again, the follow-up is quite short. So this is another large data set, almost 100 patients. And, I think we're going to need 2, 3, 4, 5-year follow-up before we know if the risk-benefit ratio is appropriate. When they look in high-risk patient populations, still looking pretty good. If the patient was POD24 or had high metabolic tumor burden, patients were still responding pretty well in these high-risk groups compared to the low-risk groups. Not quite as well, but still pretty well. This product seems to have a little better safety profile compared to axi-cel. So this might end up being a better option for follicular lymphoma, maybe. There's less cytokine release syndrome. There's less risk for neurologic toxicity with this T-cell product compared to axi-cel. There's just not as much grade 3-4 CRS or grade 3-4 neurologic toxicity. So just to kind of conclude, in follicular lymphoma, the response rates are very high for both axi-cell and tisa-cell. The durability so far, pretty good. We know 2 years, 63% for axi-cell, 1 year, 67% for tisa-cell. I think we need longer follow-up to know if this is appropriate therapy. It looks still quite active in high-risk subgroups. As I mentioned, it appears to be more cytokine release syndrome and neurologic toxicity with axi-cell. And as I mentioned, long-term cytopenias remain a concern. You know, if your patient is cured, then I guess long-term cytopenias aren't going to be such a problem. But if your patient's not cured and needs subsequent lines of therapy, then long-term cytopenias become a huge problem. So we really need to get a better handle on this. This may turn out to be a good option for selected follicular lymphoma patients. And then the last ASH abstract that I'll talk about today is actually in mantle cell lymphoma. And this is the first time I had seen much data for a bispecific in mantle cell. So I was curious to see how it would perform. So the bispecific monoclonal here is glofitamab. And so glofitamab is another bispecific monoclonal that has an arm that binds to CD20. It has an arm that binds to CD3. And like other bispecifics, it's trying to bring T cells in proximity to B cells to promote T cell mediated killing of the malignant B cells. This glofitamab is a little different than mosunetuzumab, the one I mentioned earlier. There seems to be more cytokine release syndrome with this one. So it's probably a more potent T cell engager. And there was enough cytokine release syndrome that when they designed the study in mantle cell, they decided to give it in conjunction with obinutuzumab, which is kind of curious, but they were really trying to modulate the vigorousness of the response. So obinutuzumab will actually compete with the glofitamab for CD20 binding sites. And so I think they're trying to avoid scenarios where you get too much T cell engagement too rapidly, which leads to too much cytokine release syndrome and too much toxicity. So the dosing strategy turns out to be kind of complicated, and I don't want to spend too much time on it, but they have 3 different dosing strategies where patients are being pre-treated with obinutuzumab, 1,000 milligrams in this cohort, 1,000 milligrams in this cohort, or 2,000 milligrams in this cohort. And then they have different glofitamab stepped up dosing strategies in cohort 1 and in cohort 2 and in cohort 3. So they're still working on the optimal dosing strategy. And so there's 3 patients in cohort 1 and 7 in cohort 2 and 19 in cohort 3. So there's 29 patients in total. So I'll just kind of focus on the total group. So again, it's a relapsed mantle cell lymphoma population. And they'd had the kind of things you expect in relapsed mantle cell lymphoma: prior chemotherapy, prior BTK therapy, prior lenalidomide, etc. You can see most of the patients had BTK, and there were a significant proportion of patients who had been refractory to a prior line of therapy. So again, if we just pool all the cohorts, the overall response rate is coming in at 81%, with a significant proportion of patients, 67%, in complete metabolic response. So I was impressed by the response rates for glofitamab in this relapsed mantle cell patient population. And the responses were strong, whether they had prior BTK or not, although there's only 4 patients in this BTK naive group. And then very hard to make comments on durability at this point. We just have a handful of patients, and you can see some of the patients if they have a green arrow, are in ongoing remission here. I think if it's a red triangle means there's progression of disease. So we're going to need, longer follow-up to make any comments on durability. You just can't say much about durability yet. So this is looking at the toxicity. So again, if we just look at all patients, there's quite a bit of grade 1 and grade 2 cytokine release syndrome. Fortunately, very little grade 3 or grade 4. And this just kind of tells you, when it happened. Usually cycle 1, day 1, a little bit cycle 1, day 8. Pretty uncommon by the time you get to cycle 2. So I thought this was interesting. We definitely need more options in relapsed mantle cell lymphoma. And this was the first time I had seen a significant number of patients getting a bispecific monoclonal antibody in relapsed mantle cell lymphoma. I thought the glofitamab product had high response rates, and I thought it looked promising. There's definitely some toxicity with cytokine release syndrome and a little bit of neurotoxicity. So it'd be really interesting to see how glofitamab shakes out in mantle cell lymphoma. So in conclusion, I thought it was the big ash for lymphoma. 3 trials I thought have the potential to change standard of care practices. Polarix could influence frontline diffuse large B-cell lymphoma. CAR-T could move into second-line diffuse large B-cell lymphoma for high-risk patients. And I thought there was promising data for bispecific monoclonal antibodies in follicular and mantle cell lymphoma. And the CAR-T story is emerging in follicular lymphoma, and I'm anxious to see how that plays out with longer follow-up. And with that, I will stop, and I'd be happy to take any questions.
Thank you so much, sir, for beautifully selecting very important abstracts and presenting them to us. This was fantastic, a lot of knowledge and a lot of information. I will ask the audience to put up questions in the question answer box. We have a large number of audience, as I mentioned, from 14 countries. And we have some of our colleagues from India over here who will like to ask you some question. I'm going to ask you first question, and that is related to Polarix. Once it is approved, do you think that you will be tempted to use this as first line in all the patients, or you will be selective?
That's a great question. I think I'm going to restrict the use to advanced stage IPI 2 to 5, which was the study population. And I think I won't extrapolate and start using it in IPI 0-1 or limited stage. That's how I'm feeling today. I might feel differently in a month, but as of today, I'm thinking I'll just stick to limiting its use to the study, the population that was included in the study. The toxicity isn't any worse. So you might say, well, why not just give it to anybody? One reason I think is cost. It's, our CHOP is not horrifically expensive, especially now that we have generic agents for rituximab. But I think R-CHP-POLA is going to be horrifically expensive. And so I'm going to try to be a responsible practitioner and stick to the study population for administration. The other thing I'll mention, I don't know if you all have looked at the New England Journal of Medicine paper, and they didn't show this at the ASH meeting, but look at the forest plots in the New England Journal of Medicine paper where they break out the subgroups. To me, the most fascinating part of Polarix, if you look at the subgroups, all the benefit is in the non-GCB patients. And if you look at GCB, R-CHOP and R-CHP-POLA performed like identically. suggesting there might be a cell of origin difference for the activity of the regimen, which I never would have predicted that. I would assume that this was a cell of origin agnostic agent. But now I don't think I'm going to act on that, but it is something that I think should be investigated in future studies. It's theoretically possible that our chip POLA only provides the benefit in ABC subtype, but I think we're going to have to investigate that a bit further to know that with certainty.
Thank you. Fantastic. Dr. Kripa, your question.
Yes, sir. Thank you, Dr. Bradkal. That was a wonderful update. And I have a few questions for you. So it's not uncommon in our clinical practice to see patients who are refractory to chemo totally, even to salvage as well. So how do you manage such patients? If CAR T, other than CAR T, what option you will offer? Because CAR T is not available in many countries. I mean, in USA, maybe it's freely available, but it's not in India. So if it is refractory to chemo, even to salvage line, so how do you proceed further?
Well, I'm assuming you're talking about diffuse large B-cell lymphoma right now.
Yes.
Obviously, that's a nightmare scenario you're describing. When you have people that are completely and totally chemotherapy refractory with diffuse large B-cell lymphoma, their prognosis is very poor. And for most of those patients, we can't help them right now. Obviously, we try to get them to CAR T or some, immunotherapy-based strategy. I'm curious, can you offer, like lenalidomide, rituximab to such patients?
Yes, sir, we can offer.
You can?
Yes.
Yeah. So, the response rates aren't high, but I've had a few situations where I've had chemotherapy refractory diffuse large B-cell lymphoma, and you get a very nice response to rituximab lenalidomide. That might work 2 out of 10 times or 3 out of 10 times. But when it does work, it can work very well. So that's a strategy that I have tried on occasion. I know some investigators around the country will, try like a BTK inhibitor that has low response rates, venetoclax, but there are not good options for chemotherapy refractory. And I hope, things like mosunetuzumab or glofitamab, the bispecifics that I showed that, will be literally off-the-shelf treatments that don't need cellular manufacturing. I hope those agents become available worldwide, because there definitely is a decent response rate in diffuse large B-cell lymphoma. It's not as good as it is in follicular, but we've seen some good responses in diffuse large B-cell lymphoma with those bispecifics, with response rates in the maybe 40% range. And I think that if those become available, those will become pretty good options for patients with chemotherapy-resistant diffuse large B-cell lymphoma.
And with the upcoming robust data for the CAR T-cell in the second line, where do you place polatuzumab vedotin? Apart from the POLARIX trial, like in the first line, where do you place polatuzumab vedotin in the treatment of DLBCL? With the upcoming strong robust data for CAR T-cell even in the second line.
Right. Well, right now, polatuzumab vedotin has an indication in the United States given with BR, bendamustine rituximab plus pola is approved. So that is a regimen that we will use sometimes in the third line or the fourth line relapse large cell when you're in the palliative setting. You're not treating really with curative intent anymore. So that would be probably the most common use of pola right now. sometimes we have a patient we're trying to get to CAR T-cell therapy, and we need an effective bridging strategy, and we don't want to give an anti-CD19 product. So sometimes we'll use like POLA or pola-rituximab without the bendamustine as a bridging strategy, trying to get to CAR T-cell therapy. So those would be the two most common places we're using POLA right now. It would be like third, fourth, fifth line palliative with BR, or POLA by itself just for a couple cycles as a bridge to CAR T.
So does anyone attempted allo-SCT for suppose who is really refractory post auto progression? Does anyone attempted with POLA who had a very good response for the allo transplantation among your colleagues?
Well, historically, yes, but I think with CAR T, I think the role for allo has diminished even further. You know, there was a very, very small role for allo in large cell lymphoma, and it just got smaller with CAR T cell therapy. So, you know, there'll probably be a handful of allo transplants in large cell happening every year in the country, but it's going to have a very small role because it's not that effective. And then you're bringing in the risk for chronic graft versus host disease.
Oh, one last question, sir. Sir, in a primary CNS lymphoma, like what's your experience with the usage of ibrutinib for first 2 weeks? There is a nice paper by Danley V regarding usage of ibrutinib for the first 2 weeks of therapy with a good response. So is it a routine practice to use in management of primary CNS lymphoma to use ibrutinib, and what's your experience?
So it's not routine practice. That would still be considered investigational. So none of us are using it in the front line unless it was part of a trial, but not as part of routine practice. I think many of us have used it in the relapse setting in desperation. You know, if you get somebody with relapsed central nervous system lymphoma, I've seen people get ibrutinib for patients, you know, but we're not doing it as that 2-week window as you saw in that paper yet. That's still quite new and I don't think it's quite ready for prime time.
Yeah. Thank you so much, sir, for answering my questions.
You're welcome.
Thank you, Dr. Kripa. Just taking her discussion further, the anti-CD19 antibody, the tafasitamab, do you place it importantly in the treatment of DLBCL in combination with anything?
Well, okay, that's a great question, and that's also another, I think, reasonable option for chemotherapy refractory diffuse large B-cell lymphoma, the tafa-len combination, because it's, you know, lenalidomide based. I think we're still trying to figure out how good tafa-len really is, because in the tafa-len study that was published, you know, they didn't really have refractory patients on that trial. The tafa-len data looks fantastic, but I have a feeling it was kind of a favorable patient population. So it'll be really, I think, interesting and informative to see some real world data on tafa-len. I've definitely used tafa-len a number of times in my practice because it's approved, and I've seen it work a couple times and I've seen it not work a couple times. So I don't know how good it is yet or not good. I'm happy to have it as an option, and it's well tolerated. So if you have an older, more frail patient, it's a nice option. If you have somebody who's chemotherapy resistant, it's a nice option because giving more chemotherapy is not very appealing in that situation. So I'm happy to have tafa-len, and I think it's a good option. I don't know how good yet. I have a feeling the real world data isn't going to look nearly as good as the clinical trial data. That's just a guess of mine. I don't know that for sure. It's just a feeling I have.
Thank you, sir. Dr. Bhavin?
Yeah, Thank you for selecting the excellent abstract from the ASH 2021. And at present, the CAR T therapy is the dream to us because it is not available in our country. But with the result of Zuma 7 and even the publication just before 2 days in NEJM was there about the second-line treatment of axi-cell in relapsed diffuse large B-cell lymphoma. Are you going to change your practice instead of transplant you offered? Are you going to offer the CAR T cell therapy as a second-line treatment instead of transplant, chemotherapy followed by transplant in all your patients?
Yes, but it will be limited to that high-risk population. So people who relapse within a year of their R-CHOP or R-CHP or whatever, that's the patients we're going to go to CAR T in second line, the high-risk patients. We won't replace transplant in the rest of the patients until we have data telling us it's the right thing to do. So if I have someone who received R-CHOP 4 years ago and now relapses, our intention will be to go to stem cell transplant still for that patient.
Okay, thank you.
Thank you, Dr. Bhavin. There's a question from the audience. If there is a CNS relapse, is CAR T therapy useful and should it be used as first line after the relapse?
If there's central nervous system relapse?
Yes.
Well, I've heard anecdotes of CAR T cell therapy working in central nervous system disease, but I haven't really seen a series yet to tell us what proportion of patients benefit. Is it 2 out of 10? Is it 4 out of 10? Is it 6 out of 10? That part I don't think we know yet. We are offering CAR T to selected patients with relapsed central nervous system lymphoma right now, mantle and diffuse large B-cell. If they're young and fit and healthy, we are offering it. But I admit, I don't think we know how effective it is yet. It probably will. I bet there'll be a little series we'll be able to put together in a year or so, where centers can pool their data and maybe we can look at a series of 30 or 40 patients. But I haven't seen anything yet that would tell us how good it's working.
It's another question from the audience is related to ABC versus GCB type of DLBCL. Do you differentiate their treatment upfront? And in general, do all ABC do poorly and all GCB do better?
So right now, we do not differentiate your frontline approach based upon cell of origin. Trials have tried to do that, but so far all the trials are negative. There is an ongoing global trial called Escalade for patients with ABC, diffuse large B-cell lymphoma, under age 65. They're randomized to R-CHOP or R-CHOP plus acalabrutinib, because there is some evidence that BTK inhibitors are more active in ABC, diffuse large B-cell lymphoma, compared to GCB. So if that trial is positive, there could come a day where we are having differential treatment strategies for ABC versus GCB. But right now, there's no data to tell us that you should manage those patients differently. In general, GCB patients do a little bit better than ABC patients. but I wouldn't say it's dramatically different. It's somewhat better to be GCB compared to ABC. It's a little better to be GCB, but you can still cure a high proportion of ABC patients with standard R-CHOP or R-CHIP-POLA.
Thank you. Another question is related to efficacy of CAR T therapy for extramedullary relapse of DLBCL. Is it effective?
Do you think they mean extranodal relapse of diffuse large B-cell lymphoma?
Probably he means that, yes, extranodal.
Yeah. Yeah, I don't think I've seen any data separating out outcomes by nodal versus extranodal, but my best guess here would be that it doesn't matter whether the disease is nodal or extranodal. I bet the CAR T products are similarly efficacious. That would be my prediction.
Excellent. Another question is regarding DA-EPOCH-R. So is there a subgroup of patient of DLBCL where you give this with choice?
Yes. There's 3 scenarios where I will preferentially go to dose-adjusted EPOCH-R. The most common would be in double or triple hit diffuse large B-cell lymphoma. I tend to use dose-adjusted EPOCH-R in double hit or triple hit. The second scenario where I'm likely to use it is in primary mediastinal diffuse large B-cell lymphoma. From looking at the data, it appears if you use dose-adjusted EPOCH, you're less likely to need consolidative radiation. And I try to avoid the radiation because they're usually younger patients. So that's the second scenario. The third scenario where I'll often use dose-adjusted EPOCH-R would be in an older patient with Burkitt lymphoma. Probably the most active regimen in Burkitt is the Codox-M-IVAC regimen, but that regimen is really hard to give to people over the age of, say, 40. So if I get a 50-year-old with Burkitt's or a 60-year-old with Burkitt's, I don't even try to give Codox-M-IVAC usually, and I try to give EPOCH in that scenario.
Great answer. Bhavin, a question.
Yeah. So if you permit, I can discuss one of the case with you. She is a 50-year female and she presented to us in 2019. And at that time, she has a generalized lymphadenopathy. And for that, the lymph node biopsy was done, which was suggestive of follicular lymphoma, grade 1, 2. And because she was not symptomatic, she was kept under observation. She came for regular follow-up for 2 to 3 times. And then because of the COVID, she lost the follow-up. And before 3 months, she once again came. At that time, she was quite symptomatic. She had a pleural effusion as well as the liver lesion along with the lymph nodes. So the pleural effusion was tapped and the flow cytometry was done. And even the immunohistochemistry was done on that cell block, which was suggestive of plasmablastic lymphoma and CD20 negative. And the liver biopsy was done at the same time, which was suggestive of follicular lymphoma grade 1, 2. So she was quite symptomatic. So we have started her with dose-adjusted EPOCH protocol. And because she was CD20 negative, so rituximab was not given. And along with that, because she had a grade 4 disease now, we had added the intrathecal methotrexate as a prophylaxis. After 3 cycles, she is in remission. A complete metabolic response is there. And her tolerance to treatment is excellent. So in such patient, what would you suggest further?
She's had 3 cycles now?
Yeah, she had completed 3 cycles. and she is in complete metabolic response.
Well, I guess I'm thinking your choices are either, finish out a full course of EPOC and then just observe, or I guess I'm sitting here trying to think if you would consider a autologous stem cell transplant consolidation, given what we think is really bad biology here with the plasmablastic. And that's a really hard decision. I don't, because there's no data here, right? I mean, there's zero, there's no, you'll never find any data to guide you here. So you're just going to have to guess. I probably would just finish out the EPOC and observe, and I probably would not do the stem cell transplant consolidation in first remission. But if somebody chose to do that, I would not fault them or argue with them, because I also think that would be reasonable. I don't really have a super strong opinion here about what's best for this lady. I think either of those approaches could be justified.
Yes. Yeah, we have explained her to complete 6 cycles of dose-adjusted EPOCH followed by autologous stem cell transplantation because she is young. So we thought that we should try the base whatever is possible. Thank you.
I think that's very reasonable. Yeah.
One question related to this case. Do you replace vincristine with bortezomib in this situation with plasmablastic lymphoma?
That's a great question. Yeah, there's a little bit of, like phase 2 data suggesting that could be better. And yes, so I think that would be perfectly reasonable too. Again, who really knows? But if somebody built bortezomib in, I would definitely take the vincristine out. I wouldn't give them both together, but I think that would be a fine idea too. Yeah.
Thank you. Kripa, your question.
Sir, I have one question, sir. I'm just curious to know, is gene expression profile is a routine or is it only getting done in academia? Because all trials, whatever was made as a precision medicine, none of the drugs have shown any benefit. So it's still like, is it a following like as a routine or how it is there, sir?
Yeah, we're not getting gene expression profiling, and we're to be honest, we're hardly ever doing like mutational sequencing either in lymphoma. I know some centers like Memorial Sloan Kettering are kind of routinely doing mutational profile sequencing, but I think they're just gathering up a huge database. There's not many mutations that are sort of considered actionable right now. That could change in the future as we learn more and get other agents, but I don't, in routine practice right now, there's not much of a role for mutational profiling. I guess, I don't know if you have tazemetostat in India, but that's the one drug that, knowing the mutational profile of the EZH2 gene is useful information. It kind of tells you the likelihood of that drug working. So we have one example in all of lymphoma now where knowing a mutational profile might influence a treatment decision.
Thank you so much, sir.
Thank you, Dr. Kripa. So where do you put venetoclax in the whole scenario of DLBCL treatment? Relapse setting or some genetic subtypes or upfront in combination with R-CHOP?
Well, right now there's no role for venetoclax in diffuse large B-cell lymphoma. It is being studied actively. We have a frontline trial in the U.S. cooperative group system where patients with double expressor lymphoma, so high BCL2 by immunohistochemistry, are randomized to R-CHOP or R-CHOP plus venetoclax. And that study is partially enrolled and on a pause right now for a data analysis. And if the trial meets its first signal of efficacy, then the trial will be expanded to phase 3. So there could be a role for venetoclax someday, but right now it's all still investigational.
And, is there a trend to use lenalidomide maintenance for elderly people in DLBCL now, or not much?
No.
Dr. Javed, your question.
Yes, sir. Thank you, sir, so much. Sir, Dawn study, which was actually a phase 2 trial, what they showed that ibrutinib, those people who responded very well to ibrutinib, they had upregulation of Treg, and they had down regulation of Treg and increase in interferon gamma and interleukin 2. So has it led to any thought like that in future we can use ibrutinib with interferon, or there's already any such study available? That was my question, sir.
I'm going to repeat the question to make sure I heard you correctly. I think you're asking me, are there any studies where ibrutinib is being combined with interferon to see if it has more efficacy than maybe what you'd see with ibrutinib alone?
Sir. Yes, sir. And do you have any such experience at your center before giving ibrutinib to do biomarkers like Treg, interferon, interleukin? Or it was just a single study by a single center?
Right. So I have never done that. I don't have any experience, looking at cytokine levels with ibrutinib. So I just don't know enough to answer your question. You probably know more than I do on this subject, honestly. I just don't know if anyone is studying ibrutinib in combination with different cytokines. Somebody probably is doing it around the world, but I don't know of it.
Sir, my second question is, sir, that in some cases of follicular lymphoma, a subset of patients, where we have BCL2 is overexpressed in the absence of translocation 14-18. Can we explain this mechanism? How does it happen? Overexpression of BCL2 in absence of 14-18.
Right. Well, so I can speculate. I don't know for certain, but you can get overexpression of proteins due to gene duplication, due to copy number variation. You can get protein overexpression due to defects in post-translational modification of protein. So, there's a variety of mechanisms where there can be protein overexpression in the absence of a driving translocation. And I'm assuming it's one of those mechanisms, gene duplication, copy number alteration of the gene, something like that.
Thank you, sir.
Thank you, John.
Thank you, sir.
Thank you, John. So the question related to limited stage DLBCL. So what is your present approach in these patients? How many cycles of R-CHOP? Do you change your total treatment based on PET positivity, PET negativity at the end of those cycles? Any role of radiotherapy?
Right. So if it's kind of a early stage patient, maybe without bulk, I'm quite likely to do 2 cycles of R-CHOP and then get an interim PET. And if they're PET negative after 2 cycles, I'm quite likely to just do 2 more cycles of R-CHOP and stop and omit the radiation. And there's a little data for Europe from that approach. And then we did a trial in the US Cooperative Group System. It was just published last year in the JCO. It's SWOG study, S1001. So it's just a phase 2 study, but it had over 100 patients. And with that approach of 4 cycles of R-CHOP and no radiation, if you're PET negative after cycle 2, the cure rate is over 90%, really good outcomes. And it looks like it's allowed you to spare a lot of patients radiation. So I've been using that. If the patient is still PET positive after the first 2 cycles, then I think I would be inclined to do 2 more cycles and then add in the radiation. That would be my strategy for limited stage.
Bulky disease, if it becomes PET negative, then it will be taken as non-bulky.
Right.
Okay, fair enough. The question related to the protocol of CNS prophylaxis when you're treating Burkitt's lymphoma with the DA-EPOCH-R. So how many doses of intrathecal methotrexate? Is there any fixed protocol here?
Well, Burkitt lymphoma, if you're giving EPOCH-R, and I'm assuming in the scenario we're describing, the patient has no central nervous system involvement and you're just administering it as prophylaxis. I don't know what's the best approach here, I will admit. Arbitrarily, I've just given 1 round of intrathecal chemotherapy with all 6 EPOCH cycles. So every time a patient comes in for a cycle of EPOCH, I give them a dose of intrathecal chemotherapy. I know other doctors who do it a little differently. Some doctors kind of front load it and they get more intrathecal in the first few cycles and then they stop. This is one of those nuances where I don't think we really know. But I just give 1 round with each chemo cycle.
Javid and Bhavin both have questions. Bhavin and then Javid.
Yeah. So, sir, as a CNS prophylaxis in a patients with high IPI or patients with high CNS IPI, whether do you advise CNS prophylaxis in such patient, or now with the newer data, CNS prophylaxis is not required?
Boy, I wish I knew the answer to that question. The last 2 ASH meetings, there have been some pretty compelling data suggesting that CNS prophylaxis doesn't do any good at all. And I think we're all struggling trying to decide what to do with that. In my own practice, I have been giving CNS prophylaxis to CNS IPI scores of 4, 5, and 6, for the last 5 years or so. What I saw from the data was that if you give CNS prophylaxis, your risk of CNS recurrence still comes in right around 10%.
Yeah.
And that's, if you look at that CNS IPI paper and you separate out what's your risk if your IPI score is 4, what's your risk if your score is 5, what's your risk if your score is 6, they're different. Your risk of CNS recurrence if your score is 4 is right around 10%. If your score is 5, it was more like 15%. And if your score is 6, it was more like 30%. And so going forward, I might just limit my prophylaxis to score 6 or 5 and 6 or something. I don't know. I don't know what to do here.
And that is with high dose methotrexate or intrathecal methotrexate?
I think if I'm giving I'll make up a case.
Okay.
Let's say I have someone who's got a, CNS IPI risk score of 6. they have everything bad. Lots of extranodal disease, high LDH, kidney involvement, like everything bad that makes you worry about CNS recurrence. That patient would be in that probably 30% risk group. If I'm giving them R-CHOP, I would give them intravenous methotrexate. But based on some data I saw at ASH 2 months ago, there was no difference if you try to intercalate it in between the R-CHOP versus just giving it at the end. So I think in the past, I was trying to intercalate it, which made giving the R-CHOP very complicated. I think going forward, I'm just going to give it at the end. Like get my R-CHOP in, and then maybe 2 or 3 high-dose methotrexates at the end for those super high-risk patients.
Thank you. Thank you very much.
To Bhavin. The question on testicular DLBCL. Looking at the poor long-term survival, are there any changes or modifications in the present protocol?
The question was on testicular specifically, and if we should change our current approach. Yeah. I don't think I'm going to change my approach in testicular. That seems to be a very unique biology with its own central nervous system risk. And I'm not sure the current studies can really tease that one out. So I am going to keep giving some sort of CNS prophylaxis to testicular.
Fair enough, no major change.
Yeah.
Another question is, before doing CAR T in a relapsed DLBCL, do you use any kind of treatment as a bridge to CAR T?
Try not to bridge if you can avoid it. If you can avoid bridging, I think that's better for the patient. But sometimes you have to give it because the patient has symptoms and you can't leave them, sitting in pain for a month. So it just depends. Try to avoid bridging if you can, but sometimes you just have to.
Okay. Now moving away from DLBCL, there's a question on follicular lymphoma. So if you have used bendamustine rituximab, then do you give rituximab maintenance?
Well, before COVID, I used to, but I'm not doing it anymore. I think it's kind of amazing to me. It seems like we got away with prolonged B-cell depletion for 20 years, and there was very little price to pay for the prolonged B-cell depletion. Like we were getting away with it, and by and large, the patients were doing okay. But I've had so many patients die of COVID, and I have so many patients who can't respond to COVID vaccination now that I don't think it's worth it in follicular lymphoma because it's just a progression-free survival benefit. It's not an overall survival benefit. So suddenly, it doesn't seem worth it to me to get the patient a little longer remission with no overall survival benefit, but then have this incredible vulnerability with prolonged B-cell depletion. So I'm not doing it anymore. I totally changed my practice in the last 2 years.
That's the second part of the question, that why, despite such an increase in progression-free survival, there is no impact on overall survival.
Right.
One last question left here is, we were discussing about ABC versus GCB, etc. So if you have a high-grade B-cell lymphoma with c-MYC and BCL2 or BCL6, will your approach be anything different?
The question is about high-grade B-cell lymphoma with
c-MYC, with BCL2 or BCL6.
Yeah, those patients, I'm giving dose adjusted epoch hour.
Yes. So those are the questions from the audience. Are there any questions from the faculty here?
No, thank you, sir.
That's it. Thank you so much, Dr. Karl. You have really enriched us with a lot of knowledge. Your selection of abstracts from the ASH 2021 was phenomenal. Each was very, very important. I think it's going to make an impact on our thinking process and tomorrow in the practice. And questions were also phenomenal. I thank faculty over here to ask those questions, audience to ask those questions, and you handled them beautifully, again, to the satisfaction of everybody. For official vote of thanks, we have Paresh again.
My pleasure to be with you today. Thank you.
Thank you, sir.
Thank you. Thank you, Dr. Professor Agarwal, for making Nirvana Life Sciences part of this academic feast today. Thank you, Dr. Bradkal, for sharing your knowledge and clinical experience with all of us today. I'm sure all the attendees would have certainly benefited and enriched with your session today. Thank you to all the eminent faculties who have attended this session today. Thank you. Thank you very much.
Thank you. Bye-bye, sir.
Thank you.
Thank you.